So what I did, Manny, was I sent you. I had two PowerPoints I sent you, which were the cranial nerves divided up into two bits. And what I've done is I've just put them all into one PowerPoint. So um, this PowerPoint here covers all of the cranial nerves. So we'll have a look. And that just covers all of the cranial nerve exams as well. So I'll spend a bit of time just going through this with you, because this is going to be the most important thing for you. Right. Okay. Can you see the screen okay?
Yep, I can see it.
Okay, perfect. Right. Okay, so let me give you a little introduction to the cranial nerves and talk about some specific parts. So get my pen. So in addition, we've got 31 pairs of spinal nerves and we've got 12 pairs of cranial nerves. And these cranial nerves, as you already know, these arise from the brain, and they're identified by the Roman numerals that we give them. So cranial nerves are quite unique, and that's because they contain or they have several functional components. So some of the things that I've been talking about over the last few weeks is I've been kind of introducing the topic of the nervous system in relation to general visceral efferents and afferents and general somatic efferents and afferents. So we have the similar thing here, but we also have special functions as well. So we're going to talk about that. So what we have when we talk about cranial nerves is we talk about general or special. And so this is the same general functions as spinal nerves, like we've already been talking about, but they also have special properties, which we call special senses. We still have a somatic and a visceral division, and that's related to the skin and the skeletal muscle, depending upon whether it's somatic or it's visceral. So, for instance, skeletal muscle innervation somatic, or to the smooth muscle like the cardiac muscle and the glands, the visceral component. We have afferents and efferents, and afferents and efferents mean sensory or motor functions, or both. So we're going to have a look at each one. So we're going to have a look at the cranial nerves, and then we'll look at their functional components. And then what we'll do is we'll consider their functional components into the various tests that you're going to perform when you do your cranial nerve exam. So we'll look at the first 6 to start with, and then we'll look at the related exams for each one. And we'll look at these first 6, and we'll look at their functional components in detail. So the first one we have is the olfactory nerve. This is cranial nerve number 1. And this has special visceral afferents. That's the functional component of the olfactory nerve. And it's responsible for the sense of smell. So that is the special sense that the olfactory nerve is responsible for. The second cranial nerve number 2, is the optic nerve. And this has SSA, special somatic afferents, and this is responsible for the sense of sight. The next one is the third cranial nerve, which is the ocular motor nerve. And this has general somatic efferents, and this supplies motor to the extraocular muscles. And so I'm going to just show you the importance of this in just a moment. So it has a general somatic efferent element to it, which is going to supply the motor part, and it has a general visceral efferent part, which is going to control the parasympathetic control to the smooth muscle in the eye. So it has 2 parts to it. So I'm just going to highlight this. and we'll discuss this in relation to the tests. So we've got general somatic efferents and general visceral efferents within the ocular motor. The olfactory nerve, we have special visceral afferents and special somatic afferents within the optic nerve. The fourth is the trochlear nerve. And the trochlear nerve has general somatic efferents and therefore it has motor to one extraocular muscle, okay, because it's somatic and it's efferent, engine, motor. The next one is the trigeminal nerve. And the trigeminal nerve has general somatic afferents. That means it has sensory input. And so this has sensory to the face, to the orbit, to the nose, and to the anterior part of the tongue. So this is the trigeminal nerve. And this is the sensory component of it. It also has somatic visceral efferents. And so this is the motor to the skeletal muscles of this nerve. And so again, this is broken up into two parts. It has a somatic afferent part and it has a somatic efferent part. And that's all within the trigeminal nerve. So we'll look at the branches of the trigeminal nerve and look at how that's divided. The next is the abducens nerve. This has general somatic efferent, a motor component, and this goes to one of the extraocular muscles. So let's have a look at this in a bit more detail. So these are the first six. These are the first six. I'm going to just look at them. We'll look at the first six. We'll look at the tests of the first six, and then we'll look at the second six. And so here, what we can see in the schematic underneath is we have a picture of these first six cranial nerves. So we have the first one, the olfactory nerve, the optic nerve, the oculomotor nerve, the trochlear nerve, trigeminal nerve, and the abducens nerve. So these are our first six. And so what we will look at in this picture is we have quite a nice schematic here. And the schematic is showing the different types of nerve fiber. So within the olfactory bulb, which we can see here, I'll just highlight these bits for you. So we can look at the anatomy, because we started to look at the anatomy of the brain yesterday. So here within the olfactory bulb, we have the afferent sensory fibers, and therefore we have a sensory pathway, and that's what gives us our sense of smell. So the first test that we're going to do when it comes to cranial nerve tests is we're going to want to see if the olfactory nerve is working. And the way we're going to want to test it is we're going to want to test the somatic visceral afferents, which is a sensory fiber. And the way that we're going to do that is we're going to test the patient's sense of smell by giving them something to smell to see if they can actually elicit a response. The second one is the optic. So this is the optic nerve. And so the optic nerve, again, this has sensory, special somatic afferents. And this has to do with the sense of sight. So the optic nerve, we're going to do a vision test for the optic nerve to test to see whether the patient has normal communication. And so the optic nerve, we can see here, this is the optic chiasma, right here. This is the optic chiasma, and this is the right and left optic nerve. So cranial nerve 1, olfactory bulb, cranial nerve 2, optic at the optic nerve, and these both are involved. this one, olfactory, has special visceral afferents, and the optic nerve is also a special sight. This is responsible for sight. The third one is the oculomotor nerve, and the oculomotor nerve has general somatic efferents and general visceral efferents. So the general somatic efferents is the motor to the extraocular muscles. So this is what's going to give off the motor supply to the extraocular muscles. So what we're going to want to do with this one, Manny, is we're going to want to test a couple of things here. One of the things that we're going to want to test is the extraocular muscles. We're going to want to see we're going to want to see whether the extraocular muscles are working. So if the extraocular muscles are not working, we have a problem with the general somatic efferent component of the oculomotor nerve. So what we'll do is we'll do the tests, we'll go through all the tests, and we'll look for positive and negative tests. So we'll have some normal tests, and then we'll look for some abnormal tests, and we'll discuss the different components. So that's the motor component of the ocular nerve. But there's also the visceral component. And so that's going to control the parasympathetic parts to the smooth muscle in the eye. And so that's what we're also going to look at during our test as well. And we'll discuss that. And so the oculomotor nerve, we can see the position of the oculomotor nerve. And so, as I say, we are going to be looking for the movement of the muscles, the extraocular muscles, and we're also going to be looking at the parasympathetic input of that via general visceral efferents. The next one is the trochlear nerve. And so the trochlear nerve has general somatic efferents of the motor supply to the extraocular muscles. So similarly to the oculomotor nerve, the trochlear nerve also is going to have this motor response. The next one is the trigeminal nerve. And so the trigeminal nerve, as the name would suggest, and how we started to talk about, the trigeminal nerve splits off into three parts. And so what we're going to be doing when we look at the trigeminal nerve is we're going to be looking at the general somatic afferents, which is the sensory component. So I was going to highlight that for you. We're going to look at the sensory component to the face, the orbit, the nose, and the anterior tongue. So the trigeminal nerve, because it divides off, it gives off this sensory component to the face, the orbit, the nose, and the anterior tongue. And it also has a special somatic visceral efferent component, which is the motor component to the skeletal muscles. So what we're going to do with this nerve is we're going to divide it up into its different parts. So you've got an ophthalmic division, a maxillary division, and a mandibular division. So we're going to look at each division, and we'll look at the positive and the negative tests that you get with that. Then the next one out of the first six is the abducens nerve. The abducens nerve has general somatic efferents. So this is motor to one extraocular muscle. So this is very, very specific in relation to it is the motor supply to one specific extraocular muscle. So we're going to look at how we test that. And that's to do with the gaze as well. Exactly. Looking to the side. Yeah. So we'll start with the first one, the olfactory nerve. We'll look at the function of it, and then we'll look at the tests that we're going to do with the olfactory nerve, and then we will look at the next one, which is the optic nerve. So this is the very, very first one, the olfactory nerve. So we'll just highlight some of the anatomy as well. So the olfactory nerve has only a special sensory compartment. That's the fact that you need to remember, Manny. The olfactory nerve only has a special sensory compartment, SVA. The special sensory, the special afferent not efferent because it's sensory, not motor, functions in the special sense of smell or olfaction. So this is completely sensory, and this is completely to do with olfaction. The olfactory system consists of the olfactory epithelium, the bulbs, and the tracts, along with the olfactory area of the brain, and this is collectively known as the rhinencephalon, and this is part of the limbic system. So these are the facts of the first cranial nerve that you need to know. It has a special sensory compartment. It comes under special afferents, not efferents. It consists of the olfactory epithelium, the bulbs and the tracts, and it's known as the rhinencephalon, and it's part of the limbic system. And this is the location of it. The olfactory nerve examination, because it's a sensory nerve, what we want to do is we want to test its sensory capability. So it's quite easy to test this nerve. It's simply tested by offering something familiar to the patient to smell and identify. So this could be anything, for example, an orange peel, coffee, vinegar, anything like that. Anything that has a fairly strong odor. Very little localizing information can be obtained from testing the sense of smell. This part of the exam is often omitted unless there's a reported history suggesting head trauma or toxic inhalation. So this is a part of the test, as it says, that is quite often left out, but it shouldn't be, because depending on what your patient is presenting with, and certainly for as you've got an exam coming up, you can definitely mention it. You can say, well, normally we would start with the olfactory nerve test. And the reason that we would consider doing the olfactory test is we would consider if the patient has had head trauma or has had some kind of involvement within toxic inhalation. Maybe they work in an environment which is, they work with chemicals or things like that. So although you may not actually do this test for your exam, do mention it, and do just mention about the fact that it's a special sensory, it's a sensory component, and essentially the test is just testing to see whether the sensory component is working. So the chances are that you won't actually perform this test unless they give you a specific case, or you had a specific patient who had any of these underlying pathologies. So this is what you get. This is essentially what you do with the olfactory nerve examination. You get the patient to close their eyes, you cover one nostril, and you get them to identify what they're smelling. So if it's an orange or a cup of coffee or a piece of chocolate or whatever it is. And that's the way that you can test the first nerve. So nice and simple, nice and easy, the first one. The next one is the cranial nerve, number 2, which is the optic nerve. So the optic nerve has only a special sensory component, SSA. It only has a special sensory component. Special sensory conveys visual information from the retina via special afferents. So again, this is a test in which we want to see whether the special sensory component is working. And what we're going to want to do is we are going to want to test whether the visual information from the retina via special afferents is occurring normally. So what happens is visual information enters the eye in the form of photons of light, and these are converted to electrical signals in the retina, and then these signals are carried by the optic nerves to the chiasm and tracked to the lateral geniculate nucleus of each of the thalamus, and then to the visual centers of the brain, where they become interpreted. So the visual information comes in the way of photons, and I can draw this for you. I can show you the kind of how this happens. So the visual information comes in the way of photons. It travels contralaterally, so we go up the optic nerve into the chiasm, crosses the chiasm, and ultimately goes to the region of the brain which is responsible for interpreting that image. So what we are doing with this test is we are looking for the transmission of that signal, of that sensory signal. So, as I say, we have a contralateral movement and interpretation of this image. So here we have the right visual field and the left visual field. And so what we see is that the information comes in and then travels to the opposite side, where it's processed within the primary visual cortex. So the second test, which is the optic nerve evaluation or the optic nerve examination, is tested in 5 ways. So you just want to make sure that you remember this part, Manny, that the optic nerve, we want to test 5 different components of the optic nerve. Okay, so there's 5 bits. The first is acuity, the second is color, the third is fields, the next is reflexes, and the third part is fundoscopy. So that's where we actually have a look inside. So these are the 5 different parts to the optic nerve examination. And for the in order to complete the exam of the optic nerve correctly, you need to test all of these. So you have to test all. You can't just test one and not the other. So all of these need to be looked at. Acuity, color, fields, reflexes, and fundoscopy. These are the 5 ways that we test. And so the acuity is tested with the Snellman charts, which you've probably seen whenever you go to have your eyes tested. So this is going to test the acuity via the Snellman's chart. If the patient normally wears glasses or contact lenses, then this test should be assessed both with and without. So you want to, if they do, try and get them to see how far they can go without the glasses and then with the glasses. And then that will give you a range on their acuity. So, you know, whether or not they're a 20/200 or a 20/20 vision, which is down here at this line. So this tests their overall acuity, and you're going to get patients who have who wear spectacles, and then they will get 2 different readings with and without the glasses. You know, with the glasses, maybe they're 20/20, and then without the glasses, they could potentially be something else like 20/30 or something like that. So that's the acuity part. That's the first bit here. Color vision is tested using the plates, Ischia plates, and this identifies patients who are colorblind. So with this, you can test to see whether the patient has any problems with color within their vision. So patients who are colorblind who look at this, they won't be able to see the number on the inside, which is either a 21 or a 24, depends how you look at it. You've got like a 2 here and a 1 here, or it could be a 4. I think it's a 1. Yeah. So if you're colorblind, this will all just appear as one colour. There'll be no way that you can really identify the number that's shown here. So that's the other component of it. So we've got the acuity, which is tested using the Snellen charts, the colour, which is using the Askeria plates. So just mention these things. If you actually are going to do this, you'll probably do it in an office where you've got access to these tests on the wall. If you're not going to do it and you're just going to talk about it theoretically for your patient, just mention what the tests are. Just say, I would now perform this particular test, and then I would move on to the next part, which would be to test the colour. The next part is the visual fields, which I imagine you will be able to do fairly easily because you don't really require any equipment for this. So the visual fields are tested by asking the patient to look directly at you whilst you wiggle one of your fingers in each of the 4 quadrants. So you ask the patient to identify which finger is moving, and a visual intonation can be tested by moving both fingers at the same time and checking the patient can identify this. So you've probably seen this test before, Manny, where you go to the doctor and the doctor says, okay, look at me. Can you see this? Can you see this? Can you see this? Can you see this? And then they move the fingers to see whether or not you can track if there's any change in movement. So the 4 quadrants is upper, down, on, up, down, up, down. So that's the optic nerve in relation to the visual fields. So just to cross off so far, acuity, colour, and fields, and the next 2 are reflexes, and the last one is to actually look in the eye. So the optic nerve visual reflex, this comprises of a pupillary light reflex. This is where we're going to check the response of the eye. And so you can do that with your pen torch. And most of these pen torches, when you look at the pen torches, the ones that you get in the NHS and things like that, they're like a white pen, and they've got the different size of the pupils written on the side. So it tells you exactly what diameter the pupil is. Exactly. Perfect. Yeah. So that'll tell you how reactive or non-reactive the pupil is. So what you do with this test is you place one hand vertically along the patient's nose. So you're just going to block the light from the entering the eye, which is not being tested. And then you're just going to shine the pen torch into one of the eyes, and you're going to check that the pupils on both sides constrict. So I'm going to, once I've gone through these first group of tests, I'm going to come back and talk about what you're looking for and what's a good sign and what's a bad sign. So you're looking to see that the pupils constrict. You might get a positive test on one side and you might get a negative test on the other. And so that is something that we're going to discuss in just a moment. And of course, you have to test this on both sides. It's no good just testing it on one. You have to test it on both, because we're looking at both sides of the brain. We're looking to see that both sides of the brain are functioning normally. And the last part is the fundoscopic exam. And the fundoscopic exam is the last bit that we look inside the eye, and we look at the vessels of the eye to see if there's any changes within the vasculature, or there's any degeneration within the eye itself. So we're looking at the actual structure of the eye in both in more detail. So you're looking at things like the arteries, the vein, the optic disc, to see if there's any degeneration of the optic disc or the optic cup, and the macula. So it's something called macular degeneration. And so this is the part that we look at when we look for macular degeneration. And there's also things like if your patient is hypertensive or they have things like diabetes, you can look at the arteries and look if there's any changes within the arteries, because you often see changes, especially with very, very hypertensive patients. You can see problems with that. And the optic disc, the degeneration of the optic disc is something that you're going to look for as well. So that is all of the tests of the optic nerve. So that's our second cranial nerve. So acuity, colour, fields, reflexes, and fundoscopy. And then what we'll do, Manny, is once we've gone through this first group, we're going to talk about all the pathologies and the things that you're going to see differently. So to start off with, we'll just look at normal tests, and then we'll look at abnormal tests. So the next one is the oculomotor nerve. This is our third cranial nerve. Cranial nerve number 3, oculomotor nerve. Now, as I said, the oculomotor nerve has both a somatic and a visceral component. So we're going to need to test both the somatic and the visceral component to see what's happening. So the somatic component is general somatic efference, which means this is a motor component. So this is general somatic efference, and it's a motor. And so the somatic efferent component within the oculomotor nerve does the following. It supplies 4 of the 6 extraocular muscles. So it's covering 4 of them and it's leaving 2 left. So 4 of the 6 extraocular muscles of the eye and the levator palpebrae superioris muscle of the upper eyelid. The visceral component is general visceral efference. So this is a visceral motor response. And this is the parasympathetic innervation of the constrictor, pupillar, and ciliary muscles. So what we're going to want to be testing is, we're going to be wanting to test the 4 of the 6 extraocular muscles, as well as the constrictor, pupillae, and ciliary muscles. That's what we're going to be trying to target within this. So the somatic motor component of the oculomotor nerve plays a major role in controlling the muscles responsible for the precise movement of the eyes for visual tracking and fixation of an object. So this is where we check to see whether a patient can actually track something. They can follow something in space as opposed to seeing it peripherally. The visceral component, the visceral motor component, is involved in the pupillary light reflex and accommodation reflexes. So we have 2 parts that we want to check for this. So what exam do we do for this? We do an ocular nerve examination. And what we're going to do is we're going to inspect the eyes, we're going to look for ptosis, note the appearance of the eyes, and check for ocular alignment. So we're actually going to look for the alignment. The light source reflection should fall at the same location on each eyeball. So one would hope that the eyes are equal. There's not one going one way and one going the other, or each way. So the next test is the extraocular range of motion. And the way that you do this is you have the patient follow a near target through the principal position of gaze. And so the H pattern, you look for any misalignment of the eyes or complaints, which can be, you get the patient to track your visual, to track a visual target, to look up, look down, look left, right, and to look straight ahead and to see if there's any abnormal movement. So when specifically evaluating this, you want to note the following. You want to note adduction of the medial rectus, depression whilst abducting, which is via the inferior rectus, and elevation by the superior rectus and inferior oblique. So that's the groups of muscles that you want to see are functioning normally within the oculomotor nerve test. Pupillary constriction is tested by the light reflex. So the light reflex is going to tell you whether the pupillary constriction is happening normally. And having the patient focus on a near target can test accommodation. So loss of cranial nerve number 3 can cause diplomia and the eye that is drawn down and out. So this is where the eye, it comes down. I think I've got an example on the next slide. Oh, I do. Yes, I do. I have one further on. So if the eye is, if you're getting the patient to look at you straight and their right eye is looking straight at you, but the left eye is kind of pointed downwards and outwards, it's an indication that there is something wrong with the oculomotor nerve. As opposed to, let me just give you 2 different examples. We'll have this one here. It's going to draw you a stupid picture. So here's a face. This is an eye. This is another eye. Well, it's already deranged, but okay. Well, that's actually worked out quite well. It would, so if you're getting the patient to look directly at you, and this eye, this one is fairly reasonably in the middle. Now this eye was supposed to be kind of down here like that. So if it's coming downwards and outwards, that's an abnormal sign. And that's different from the test that we did here. It's not the same, because what we're testing with the optic nerve is we're looking for the reflex and we are checking for the visual fields, but we're not specifically looking for the tracking ability. So in a way, what you will find, Manny, is when you're doing your optic nerve examination, you will find indicators at this first test that it relates to the oculomotor nerve. So there's 2 components. It's like it's the same test but spread over different parts. So you might well be doing the optic nerve examination and you notice that the patient's eye just kind of goes down and tracks off, and you're going to think, okay, but you don't make that specific diagnosis at that point until you get to the next bit, although you're already aware that there's something going on because you've already started to look at it, if that makes sense.
That makes sense. I'm guessing you're talking about things like third nerve palsy and things like that.
Exactly. Yeah, exactly. Yeah. Because I mean, a lot of these things you know straight away before you, I mean, in some cases, before you even put a light in somebody's eye, you can see it. You know, it's quite clear that there's something that's not there. But so you just follow the steps. So the oculomotor nerve exam, we're looking for any changes there. Then the next one is the trochlear nerve, and the trochlear nerve has only a somatic motor component. So we've got a somatic motor, general somatic efference, E for engine. The somatic motor innervates the superior obliques of the contralateral orbit. So these are the somatic motor innervation of the superior obliques of the contralateral orbit. And so what we do with the trochlear nerve is we have the patient adduct and look downwards to the nose, and this best isolates this particular nerve. So the trochlear nerve, you try and get the patient to look down towards their nose. And so if they can't do that, you have a test which can suggest that there is trochlear nerve involvement. So the trochlear nerve is the only nerve to exit from the dorsal aspect of the brain, and it has the longest intercranial course of any of the cranial nerves. And because of that, it is often the most susceptible to things like damage from intracranial lesions caused by trauma, inflammatory disease, and compression. And we can see you often get patients who have a compensating head tilt to try and manage this or overcome this, because when they look down into try and track, they can't do it. So they try and move their head to try and manage it. So the thing to remember with the trochlear nerve is that the test is to get the patient to look downwards, and you're looking to see whether or not they can their eyes contract down into that middle field. And also remember that the trochlear nerve is the most common one that is damaged in trauma and inflammatory disease. So if you've had somebody who's had some kind of head trauma, or they've had an inflammatory disease or a compression of some type, this is often the one that you're going to see changes with. The next one is the trigeminal nerve. And so this is the largest and the most complex of all of the cranial nerves. And that's because of the way it divides up. It supplies sensations to the face, to the mucous membranes, as well as other structures of the head. And it exits the brain by a large sensory route and a smaller motor route. So it has a sensory and a motor component or route. And so what we need to do is we need to kind of break it down and look at the different parts. So it exits by the larger sensory route, and it has a smaller motor part which comes out of the pons at its junction with the middle cerebral. The ophthalmic, maxillary, and mandibular branches of the trigeminal nerve leave the skull through 3 separate foramina. And these are the superior orbital fissure, the foramen rotundum, and the foramen ovale. So we've got the 3 parts, which we will highlight as well. So we've got the maxillary and mandibular branches leave the skull through these 3 separate foramina, and these are the superior orbital fissure, the foramen rotundum, and the foramen ovale. So you've got the 3 bits leaving the skull through these areas. So we need to do a test to see the different parts and whether the different parts are intact. So we've got a sensory portion to the test, and the sensory portion of the trigeminal nerve is commonly tested by examining the integrity and symmetry of pain and light touch sensation from all areas of the face. So this is all the way from the forehead down to the cheek and down to the jaw. So you're going to test both sides to see if the patient has got normal sensation. So you can either use like an object like the doctor's using there, or you can use your fingers just to gently touch each side of the forehead, ask the patient if they can feel it, and ask them if it feels symmetrical as well. So sometimes you see this test done in a few different ways. I've seen it done in several ways over the years. Some people test one side and then they test the other, and they say, okay, can you feel this? Does that feel, does it feel hot or cold? Is there any pain or discomfort? Is there any numbness? Is it hot, cold, any pain, discomfort, or numbness? They'll go down one side and then they'll go down the other. And then there's some who advocate for testing both sides. I actually think that testing both sides at the same time is a good idea, because you want to see if there's parallel on either side, rather than going down one side and then going down the other. You can see whether the patient, does this feel, does it feel both? Does it feel the same on both sides? Does one side, for instance, feel hotter than the other side? Or does one side feel more numb than the other side? Is there more pain in one side than there is in the other? And so what it does is it gives you a division of the two sides. And so you can see, whether the left side is more susceptible or more sensitive, or the right side is more susceptible or more sensitive. So after asking the patient to close his or her eyes, a tissue can be lightly touched to one side of the forehead. So here they're saying one side. So, some people will choose to do it one-sided, or you can do it both-sided. Like I say, over the years, I've seen it done both ways. So the tissue is then touched to the opposite side of the patient, is asked to compare sensations, whether they have a sharp object, whether they can feel any pain. And what you're looking for is the testing of sensation and the symmetry. And so that's the point that I'm trying to get across with symmetry. When you test both sides, you do get a good indication of symmetry, because sometimes I've had patients who've got a palsy, and you're coming down and you're saying, okay, can you feel anything? They say, yeah, only on the left though. Only on the left though. Only on the left though. So there's nothing on the right side. They don't feel anything. Or they might say, yeah, I can feel it both sides, but it's really prickly on the left. It's really prickly on the left, or it's really prickly on the left. So that can just give you a good indicator of symmetry as well. So the test is then repeated on the cheek and the jawline to assess the second and third division. So each part is testing a different division. So you've got the upper part, middle part, and lower part of the nerve, just to test all three divisions of it. And so this is how you're going to actually test the different bits. So for the examiner, before you perform the test, you'd explain to the examiner, okay, I'm going to start off by checking the ophthalmic branch, and then I'm going to elicit a test to see if the ophthalmic branch is okay. The next part I'm going to do is the maxillary branch, and then I'm going to test the mandibular branch. So you're going to want to test each part, and you're going to be wanting to test to see whether there is normal sensory input and whether there is symmetry from left to right. So you're going to test 1, 2, 3, 1, 2, 3. And as I say, depending on who you speak to, some people will be very, very much about, okay, you test the ophthalmic on the right, and then you do the ophthalmic on the left, and then you do the maxillary on the right, then you do the maxillary on the left, then you do the mandibular on the right, then you do the mandibular on the left. And then you might have other practitioners that will do the ophthalmic left and right, maxillary left and right, mandibular left and right, and then they may even go back and then do them individually again as well. So different people have different ways of going about it. This one that I'm showing you here, they've just mentioned about doing it independently, individually. So either way is fine. You just want to see ultimately what the result is. So a bit more about the trigeminal nerve examination. An additional test used to evaluate the trigeminal nerve is the coronal reflex test, which is the blink test. So this is a test that you can also perform after this. So first of all, do the divisional testing, and then you can do the coronal reflex blink test. And so what this is going to do is this is going to evaluate the reflex by gently touching each cornea with a cotton wisp and observing any asymmetries in the blink response. This tests both the sensory, fifth nerve, and the motor portion of the seventh nerve, which is responsible for lid closure. Now, what you'll find, Manny, is that a lot of people don't do this test. You'll find, I don't know, did they even talk to you about this part, the blink test?
Yeah, they taught it. It's one of
Oh,
those
they did.
Yeah, it's one of the invasive tests that they said
Ah,
only.
they class it as an invasive test, do they?
Yeah.
Yeah.
So it's kind of like the jaw reflex as well, the one where you smack on the jaw.
Yeah.
It's the same principle.
Yeah. No, that's about right. I mean, a lot of people, they'll try to avoid doing it, but it really depends on your patient's pathology, which is what we'll talk about in just a moment, and we'll look at the significance. Because certainly, if you've got somebody who you're not particularly worried about, and you're just doing it for the, just the standard evaluation, then it may not be necessary to do. But then, if you've got any concerns, you definitely need to do it. So. The next thing is to test the motor component. And in order to do this, we want to feel and compare the tone of the masseter muscles during jaw clench. So this is just what you were talking about. So the next is you have the patient open his or her mouth, and the examiner should attempt to close it. If there is weakness of the pterygoids in the jaw, so we started to talk about the medial and lateral pterygoids yesterday, which is why I wanted to cover the TMJ with you, because it all kind of links in. We were talking about the TMJ yesterday and changes within TMJ. So if there's weakness of the pterygoids, the jaw will deviate towards the side of the weakness. So we're looking for deviation of the jaw, like we started to discuss yesterday. So sensory loss of this is usually due to things like trauma, while vascular damage, tumours, and trauma can result in damage to the motor aspect of the system. So there's several things that can be an underlying thing. We started to talk about TMJ yesterday, but this can also have an element such as vascular damage and tumours as well. So if a patient has got even certain types of brain tumour, you will be able to note via these examinations, via these cranial nerve examinations, which we'll discuss. The next is the abducens nerve. The abducens nerve has only a somatic motor component. So the abducens nerve is only somatic motor. Somatic motor, general somatic efference, and the somatic motor innervates the lateral rectus muscle of the ipsilateral orbit. So this is the abducens nerve. And so this is what we see when testing the abducens nerve. The abducens nerve supplies the somatic efferent motor fibers to the lateral rectus muscle. So it supplies the somatic efferent motor fibers to the lateral rectus, which functions to abduct the eye. As in prior discussions regarding the extraocular muscles, having the patient follow a near target and tracing the letter H pattern tests the abducens nerve. So if you get the patient to track an H, you can see whether or not there is any changes within the lateral rectus muscle to see if the lateral rectus is working. So if the patient has an inability to abduct the eye, this indicates a possible deficit. And so some of the things that can be a cause of this can be things like aneurysms, tumors, meningitis, trauma, and cavernous sinus pathologies. So that this is a very, very, very important test. All of the eye tests are very, very important. They tell you so much what's going on with the brain, huge amount. I mean, hence the reason if you ever work in like an A&E department or something like that, and you get patients coming in with a head trauma, you do these standard tests just constantly throughout the day. You come in, you're checking their eyes, checking the light reflexes, checking their tracking, you're doing a GCS. Oh, I'm going to send you that, Manny. I'm going to send you a GCS chart today. So that's for you, that you can keep and just have a look at, so you get used to seeing what they look like within the National Health Service. So we're checking for eye movements of this. Some of the symptoms of nerve damage, you're going to see things like the affected eye will tend to be deviated inwards because the unopposed action of the medial rectus muscle cannot move laterally. So here we've actually got an example of this in this picture with this patient. So you can see the injured side and the normal side. So on the normal side, the patient's looking over to his right hand side, and the injured eye is unable to move. So there's no movement here. So these are really, really significant sides. So that's going to be an indicator that there is something going on with the left hemisphere of the brain, because it's contralateral. So when we think about things like meningitis, and we think about things like tumors or pathologies to the cavernous sinus, we're thinking about contralateral pathologies. So one of the things that we started to touch upon yesterday was the brain and the different parts of the brain, and that links on perfectly to this. So before we go on to the next group, I just want to cover these points with you just in relation to pathologies. So we'll just talk about pathology. So we've talked about normal testing with these first few, and so now we'll just talk about some abnormal tests. So the olfactory nerve, ultimately, it's because it's going to be related to our sense of smell. This is a fairly simple, simplistic test. If the patient can't smell anything or can't give you any kind of response to the stimulus, we're aware that there's something wrong with the olfactory nerve, and therefore it could be that they have some type of sensory deficit in relation to that. Now, the next group of nerves, the optic, the oculomotor, the trochlear, the trigeminal, and the abducens nerve, they all come together as one, in as much as they are all to do with visual processing and movement and tracking of the eye. So what you will find, and what I was saying, was that really when you get to the first exam, which is the optic nerve exam, you're going to start to get an indicator of some of the other problems that the patient might be having. Because as soon as they sit down and you look at them in the eye and you get your pen torch out, you're already instinctively looking for their normal tracking, and you're looking. So although you're not getting them to look up, look down, look left, look right, make an H, you're not doing that quite yet, but you instinctively start to get an indicator about some of the later tests. So the first test, this optic nerve test, in relation to visual, it's not the first test. The first test is the olfactory nerve, but the first test in relation to vision, the optic nerve, you are looking to see whether or not there is any damage to the eye itself, the physical damage to the eye, by testing things like acuity, color, fields, reflexes, fundoscopy. And the types of pathologies that you want to consider are your stroke patients. So we started to talk about patients who had a stroke. So a patient who has maybe had a stroke or a series of strokes may very well have deficits in one or more, if not all, of these. So we want to look at whether anything has changed within the brain which has caused any of this to change. So these are your standard tests for that. The visual fields and checking the visual fields, again, as I say, that comes back to the later visual test as well, because here we're also looking for pathologies within the brain. So these are your sports persons, your rugby players, your football players who've had injuries, and maybe potentially they've had neck injuries, or they've had, they've had concussion recently, and they've started to complain of things like headaches, blurred vision, things like that. These are tests that we want to look at. And the pupillary light reflex test is a really, really important test. And as you've got your pen torch with you there, and it gives you the different millimeter diameter of each eye. When you look at the eye from left to right, so if that's the right eye and then this is the left eye, and you're flashing the light, and you find that the right eye has a normal pupillary light reflex, and you find that the left eye doesn't, just remains open, as it were, you are concerned that there is a problem with the contralateral side of the brain. So you're concerned that there is something which is causing that reaction to not occur. Also, the fundoscopy is a really important exam. Have you done the fundoscopic exam, Annie, or is it not something that they get you to do?
No, they told us to do it, but the only problem with it is our fundoscopes are not exactly equipped to look at the eye. You have to spend a good 300, 400 pound on one.
Absolutely. Yeah, no, I mean, it's not something that, it's not cheap at all. And if you're not working in a hospital setting, it's not something that you're going to immediately have to hand. So yeah, no, absolutely. No, it's if you if you've got one, great. But like you say, I mean, you want to get a decent one, and they cost several £100s to get a nice one. And you really, ideally, if you're working in a hospital setting, it's fine because they're on the wall in every area, and you could standardly do it. But as an independent practitioner like you may not even have access to one. So, but it is an important component of the exam, because you can take a lot from this, and this is good for patients that you've got who are like very, very hypertensive, type 2 diabetic patients, diabetic retinopathy, things like that. Diabetic retinopathy is a huge problem. Lots and lots of people, especially in the UK and America, are suffering with type 2 diabetes. It's becoming more and more of a problem, massive problem now. And diabetic retinopathy is a huge problem. So I try and incorporate it into my examination. But then, the same as you just said, Manny, I don't have one. I don't have one to hand. So the only time I would be able to do it is when I'm in somebody else's clinic, or if I'm in the hospital. But it's a really important test. And I would say actually that now, with the current climate of just how many people we're getting with heart disease, heart conditions, atherosclerosis, diabetes, hypertension, hypertensive disorders, this should just be more and more of a standard test, as much as doing a general blood test, really, because it's becoming much more of a problem. So just continuing on with the pathologies, that things like the ocular nerve examination will give you indications on whether the eye, as we discussed, the movement of the eye, And this is in relation again to things like patients who've maybe had a head injury, or patients who potentially may have a tumor as well. So all of these cranial nerve tests in relation to vision, visual fields, visual tracking, give off a huge indicator of things like tumors in the brain, compression on the brain, damage to the actual eye itself by things like hypertensive disorders, and other diseases like we started to discuss. The trigeminal nerve, as I said, it's a really complex nerve. It's the most complex of all of the cranial nerves. And the things that you're going to want to do is, as we said, you're going to want to standardly check the ophthalmic, maxillary, and mandibular branch. As you said, this is the corneal reflex or blink test is a more invasive test, but this is the kind of test that you want to get with your patients that may be following on from the trochlear nerve and the oculomotor nerve and the optic nerve examination. You have concerns, they're not tracking, their eyes going off to the side, they've also had a recent head injury and things like that. Then you're going to want to elicit this additional part of this test for these group of patients. The other part in relation to the jaw kind of links on to what we were talking about yesterday. And so testing the jaw is really, really important to do as well, to see whether or not there is any laxivity within the jaw and there's any damage to the pterygoids. And, an underlying cause of that could be several reasons. It could be that the patient has had some kind of head trauma. They could have had a trauma to the jaw itself, especially sporting people, like boxers, rugby players, other types of athletes who maybe have had like dislocations or recurrent dislocations of the jaw, locking jaw syndrome, things like that. These are all things that you're going to want to consider. Okay, so we need to look at some other nerves. So the next one we want to look at is the facial nerve, and we'll look at the functions of the facial nerve. So the facial nerve has specific functional components. It has GSA, SVA, GVE, and SVE. So GSA is the sensory to the skin of the ear, specifically to the ear. This is the general somatic afferents, the general sensory to the skin. We have the special sense of taste to the anterior part of the tongue. We have a motor part to the salivary, nasal, and lacrimal glands. This is the motor compartment. And we have a motor compartment to the facial muscles. So we've got sensory to the skin of the ear. We've got special sense of taste to the anterior part of the tongue. We've got the motor part to the salivary, nasal, and lacrimal glands. And we've got the motor part to the facial muscles. This is all part of the facial nerve. And so we'll have a look at the facial nerve. So the facial nerve has 4 components with distinct functions. It has a brachial motor, which is a special visceral efferent component, and this supplies the muscles of facial expression, the posterior belly of the digastric muscle, the stylohyoid, and the stapedius. This is the brachial motor visceral efferent branch. So belly of digastric, stylohyoid, and stapedius. It has a visceral motor, which is general visceral efferents. This is the parasympathetic innervation of the lacrimal, submandibular, and sublingual glands, as well as the mucous membranes of the nasopharynx, the hard and soft palate. That is the general visceral efferents. We have a special sensory, a special afferent pathway, and this relates to taste sensation from the anterior two-thirds of the tongue and the hard palate and the soft palates. And then we have general sensory, general somatic afferents, and this is the general sensation from the skin of the concha of the auricle from a small area behind the ear. So what tests do we do for the facial nerve? We do the following tests. To test the motor division of the facial nerve, we're going to start from the top and work down. So we'll go from the top and come to the bottom. First, you're going to have the patient wrinkle the forehead and check for asymmetry to see whether or not there's one side that's activating and one side that's not. The next is to have the patient shut the eyes tightly whilst the examiner attempts to open them, and you're going to look for any weakness. So start with the forehead, then with the eyes, try and open the eyes, then have the patient puff out their cheeks in an attempt to hold air, and finally have the patient show his or her teeth or smile and compare the nasolabial folds on either side of the face. So these are the different components. Forehead, wrinkling of the forehead, looking for symmetry, both sides. I'll just highlight these points. So looking for symmetry, both sides. Whether one side is lax and one side is not. So it's symmetrical on this picture. Patient then closes their eyes and you try and open the eyes either side. They should be able to keep them closed. If they can't, that's a positive test. And then filling up the cheeks, seeing if there's normal ability to do that. And then to open the mouth, show the teeth, and you look for normal facial, no deviation either side. So that's the facial nerve. The facial nerve is, as I say, has the mixed components. So the next one is the vestibulocochlear nerve. So we'll look at that one. We'll look at the specific parts of that. So it has special sense of hearing and balance. That is its main property, SSA. Special somatic afferents. So the vestibulocochlear nerve, it's the main sensory supply of the internal ear. It has two major sets of fibers, one set from the vestibular nerve, concerned with equilibration and arising from neurons in the vestibular. The other set of fibers form the cochlear nerve, arising from the neurons in the spiral ganglion of the cochlea. And the nerve emerges in the groove between the pons and the medulla oblongata, and this is behind that of the facial nerve. So the facial nerve is before it. The eighth cranial nerve carries two special sensory afferent fibers, one for audition, which is hearing, and the other is for vestibular function, which is to do with balance. So part of this is to do with the ability to hear, and the other part is to do with balance. So the test that we're going to do with this is the Rinne-Weber test, and this test is used to perform and can help differentiate between conductive differences from neurosensory lesions. So here we're looking for to see if there is any changes in the equilibrium or in the hearing itself. Have you done this test before, Manny?
Yeah, I think it's Weber's, which is on the vertex, and then you check which side they're feeling it, and then Renee's is the one where you hit the tuning fork, put it on the styloid, ask them when they stop hearing it, stop
Yeah,
feeling it, and then put it near their ear, and then tell them
yeah,
can they hear.
yeah, exactly. Perfect. Yeah. So that's a pretty standard test that you do there. And it's not really invasive. So there's not a problem with doing that with all of your group, really. The next one is the glossopharyngeal. So I'll just come back just for a moment. So the next one is the glossopharyngeal nerve. And the glossopharyngeal, again, has GSA, sensory to the posterior part of the tongue. It has SVA, special sense of taste to the posterior part of the tongue. GVA, which is sensory from the middle ear, the pharynx, and the carotid body and sinus. GVE, motor to the parotid gland. And SVE, which is motor to one muscle of the pharynx. So this is all within the glossopharyngeal nerve. So we'll look at the glossopharyngeal nerve in a bit more detail. So the glossopharyngeal nerve consists of 5 components. It's got 5 different parts with distinct function. It's got a branchial motor, which is special visceral efferents, and this supplies the stylopharyngeus muscle. It has a visceral motor component. This is the parasympathetic innervation of the smooth muscle and the glands of the pharynx, larynx, and viscera of the thorax and the abdomen. It has a visceral sensory component, which carries visceral sensory information from the carotid sinus and the body. It has a general somatic afferent path, which provides sensory information from the skin of the external ear, internal surface of the tympanic membrane, and the upper part of the pharynx, and the posterior 1/3 of the tongue. And then it has a special afferent channel, which provides the taste sensation from the posterior 1/3 of the tongue. So the gag reflex test is the test that we're going to use to test the glossopharyngeal nerve. And the gag reflex tests both the sensory and the motor component of this cranial nerve. It also tests cranial nerve 9 and 10. This involuntary reflex is obtained by stroking the back of the pharynx with a tongue depressor and watching the elevation of the palate, as well as causing a patient to gag. So this is the gag reflex. The motor division of cranial nerve 9 and 10 is tested by having the patient say ah or ka and seeing if there's any change within that. The palate should rise symmetrically in the back of the oral cavity. So when you get them to open their mouth and go ah, ka, you can actually use your pen torch just to have a look in the mouth to see if there's any change in the symmetry at the back of the oral cavity. Paralysis of the 9th cranial nerve causes a pulling on the uvula to the unaffected side. So if you have a patient who has some kind of palsy, some kind of lesion, some kind of brain lesion, and you look in the back of the mouth, you can see the uvula will be going to the left or right side. So it will go to the unaffected side. The 9th, 10th, 11th cranial nerve pathways are physically too close together to isolate the lesions and are rarely seen. So the deviation of the uvula is an important one. That is one that you do want to look out for. And so this is how you perform the test. You get the patient to open the mouth. You can use a tongue depressor and you can say ah, ka, get them to say that. And you look at the uvula and you look to see whether or not there is any deviation of the uvula to the left or the right side. If there is a deviation, it can be indicative of some type of lesion. The next one is the vagus, our friend the vagus. So I'm just going to go back a few bits and cover some parts of the vagus. So the vagus nerve, big nerve. Vagus means wanderer because it wanders here, it wanders there, it wanders everywhere. It has a GSA component, a GVA component, a SVA, GVA, GVE, and an SVE component. So the GSA is a sensory component to the external ear. It has a special sense of taste by the epiglottis. It has a sensory component from the pharynx, the larynx, and the thoracic and abdominal organs. Has a motor supply to the thoracic and abdominal organs, and it has motor to muscles of the pharynx and larynx. So very, very widespread division, as we started to discuss when we went over the general pathway of it. So the cranial nerve, vagus nerve. Vagus is from the Latin word to means to wander. It's because he goes here, he goes there, he goes everywhere. This is a fitting name as the nerve wanders from the brainstem to the splenic flexure of the colon, and the vagus nerve consists of 5 components with distinct functions. So we'll have a look at that. And so here you can actually see just how diverse the vagus nerve is. And certainly last week we started to talk about the division of the sympathetics and the parasympathetics. And I've kind of given you a little introduction into how when we get the development of the nervous system and we have the development of the sympathetic and the parasympathetic nervous system, how when we have cranial and caudal folding, from the cranial end, we have the vagus nerve that comes down. And so here we can actually track the whole thing down. We have the left vagus nerve comes down, and then the vagus nerve loops around and becomes the recurrent laryngeal nerve. It gives off a cardiac plexus. It gives branches off to the cardiac plexus. It gives off an esophageal plexus. It gives off a pulmonary plexus. Anterior, it gives off gastric branches, and on and on and on and on. And it comes all the way down right up until when we discussed about the gut, we started to talk about the gut. And I said that we've got right up to this last third of the transverse colon. We have all of the vagus nerve coming down right over to the part of the left colic flexure. And then everything from down below is still parasympathetic. But as I said, it's not called the vagus anymore, although really it kind of is all one thing because the axons communicate. But so that gives us just a general schematic of the overall vagus nerve. So let's look at the 5 different parts of it and look at how we can test this in more detail. So it's got the motor component, which is going to supply the voluntary muscles of the pharynx and most of the larynx. So it's got the motor component plus supplying the pharynx, most of the larynx, as well as the extrinsic muscles of the tongue. You've got the visceral motor. This is the parasympathetic innervation of the smooth muscle and the glands of the pharynx, the larynx, and the viscera of the thorax and the abdomen. You have the visceral sensory component. This provides visceral sensory information from the larynx, the esophagus, the trachea, and the abdominal and thoracic viscera, as well as the stretch receptors of the aortic arch and the chemoreceptors of the aortic bodies. You've got the general sensory, general somatic afferents. This provides the general sensory information from the skin of the back of the ear and the external auditory meatus, parts of the external surface of the tympanic membrane in the pharynx. And then finally, you've got the special sensory, special afferents, which is a very minor component, and it provides taste sensation from the epiglottic region. So the vagus nerve carries sensory afferent fibers from the larynx, trachea, esophagus, pharynx, and abdominal viscera. It also sends efferent motor fibers to the pharynx, to the tongue, to the thoracic and abdominal viscera. The testing of the vagus nerve is performed by using the gag reflex again and the R test as described before. A unilateral lesion affecting the vagus nerve can produce hoarseness and difficulty swallowing due to the loss of the laryngeal function. So patients who have problems with swallowing and who have suddenly developed this, as well as problems, they've got a change in the pitch and the tone of the voice, and the voice has become more hoarse, you are thinking more in the realms of a cranial nerve, a vagus nerve injury. And so similar to the other test, we can look inside the mouth and get the patient to make the R, and we can have a look, again, you're looking at the overall posterior part of the oral cavity, and you're looking for normal tone within the voice as well. So the next one is the accessory nerve. We'll look at the accessory nerve, look at the different parts of the accessory nerve. The accessory nerve has motor to SVE, motor to two muscles. So this is the spinal accessory nerve. And so the spinal accessory nerve, we'll look at the different components of the spinal accessory nerve. So the accessory nerve has a cranial root and a spinal root, and both of which consist of brachial motor fibers. The brachial motor, the cranial root, has special visceral efferent, and this innervates the muscles of the larynx and the pharynx. And the brachial motor spinal root, the special visceral efferent, innervates the trapezius and the sternocleidomastoid muscle. So this is specific. This makes the test even more specific because it innervates the trapezius and the sternocleidomastoid muscle. So what we're going to want to do is we're going to want to test the trapezius, and we're going to want to test the sternocleidomastoid muscle. And so what I've done, Manny, is for the next part of the session today, I've linked this on to upper limb assessment. Well, I say upper, it's actually upper and lower limb assessment, because what we'll see is there's a lot of links with different types of head injuries and traumas and lower limb palsies as well. So it just kind of follows on to do that. So the accessory nerve carries efferent motor fibers to innervate the sternocleidomastoid and trapezius muscle. The accessory nerve is tested by asking the patient to shrug the shoulders, the trapezius muscle, and in turn turn the head, which is going to test the sternocleidomastoid muscle. And you're going to do that against resistance. So the two major things that you're going to test for is shrugging the shoulders by the trapezius muscle, which I'm sure you've done hundreds of times, very, very pertinent to your work, and testing the movement of the head, the sternocleidomastoid muscle, to look if there's any damage to the accessory nerve. You're going to palpate the patient's sternocleidomastoid and feel for tension as the patient attempts to turn his head or her head. So loss of this can cause a drooping of the ipsilateral shoulder and the trapezius on the affected side, and the patient may also have difficulty in turning his head. And damage usually occurs secondarily to surgery or trauma. So this can be something that has occurred after surgery. So this might be a patient that comes to you post-surgery, several weeks or months or maybe even years after surgery. they're starting to have all of these complications. And so you're concerned that the accessory nerve has been damaged in this particular case. Good. Now, last part. So the next one is the hypoglossal nerve. And the hypoglossal nerve is responsible for motor control to the tongue muscles. So we'll look at that. Okay, so the hypoglossal nerve, it only has a somatic motor, general somatic efferent component. The somatic motor component innervates all of the intrinsic and most of the extrinsic tongue muscles. It supplies 3 of the 4 extrinsic muscles of the tongue, including the genioglossus, styloglossus, and the hyloglossus. And the palatoglossus muscle is supplied by the vagus nerve. So if it's the palatoglossus that is specifically affected, it's in relation to the vagus nerve, as opposed to the genio, stylo, and hylo, which are all part of the hypoglossal nerve. The 12th cranial nerve supplies the efferent motor fibers to the muscles of the tongue. To test the hypoglossal nerve, you have the patient stick out their tongue and move it side to side. If there is unilateral weakness, the protruded tongue will deviate towards the side of the weakness. So you can use a cotton bud, and you can get the patient to put their tongue out and to push away with the cotton bud. And you might find that on one side they can do it really very well, and the other side they have very limited ability to do so. So these are the types of things you're going to want to consider. So that is all of the basic cranial nerve testing. So we'll just go through and just recap on the exams in their order, because the thing that you want to do is make sure that you do them in order. And now what I've seen, and it's difficult sometimes to do them in order, and I've seen over the years, I was an OSCE examiner for a little while, and all of the students had to come in, and we'd have like a checklist, and they'd have to go through each one. And quite often they would do things like maybe they would check the ocular motor before the optic nerve and things like that. So try and do it in a logical order as much as you can. So there's a few different ways you can do. There's a few different techniques that you can try to help you do this before you start the exam. You can set your equipment out in such a way that you've got it laid out for you, so it helps you to guide the different tests that you're going to do. So for instance, if the first thing that you're going to do is the olfactory nerve, maybe just place the cup of coffee or whatever it is that you're going to get them to smell, to orientate yourself to the order of events. And so that's the first one. For your case, I'm not entirely sure whether, depending on the type of case that you've got, whether or not you're actually going to perform this test. But it's definitely worth, if you don't actually perform the test, it's definitely worth talking about it to the examiner. If you've got an OSCE examiner, I mean, you don't, like a lot of the time, the examiner's not just looking forward for you just to go through and do A, B, C, D. They just want to see your knowledge. So you can, you don't always have to perform certain tests. Like, for instance, this one might not really even be very pertinent for you, but it could be if the patient is specifically, working in an environment where they're involved with chemicals, or they've recently lost their sense of smell. One of the things with COVID is that they say that patients have lost their, one of the side affects is that they lose their ability to smell. So, I mean, things like that you can just talk about within your differentials. Then the next one, the optic nerve examination. You can have, depending on where you're doing this. So if you're doing this in a university setting or a college setting, you'll normally have all of these charts and tests around you. So, you know, you'll have the Snellen's test there. If you don't, you can have, sometimes you've got these little cards that you can have in your pocket or in your folder, which you can take. So just try and get the tests laid out in a certain order. So, for example, the first part of the optic nerve is the acuity, and so you would want to set out the Snellen's test as the next part to have that prepared. So you'd have the Snellen's test, you'd go through, you do the acuity test with them, then you do the exterior plate test to look for color blindness, to see if there's any signs of color blindness. Then you would want to do the visual fields. So get those tests out of the way, then do the visual fields, checking to see if the patient's visual fields are intact. Then you can go back to your pen torch and look for the pupillary light reflex. And one of the things that you can do here, Manny, is while you're doing this test, talk to the, if you've got an examiner there, talk about what normal pupil dilation is and what abnormal pupil dilation is, and discuss things like why a patient might have a blown out pupil. So, for instance, you know, you could say, you know, I'd be particularly concerned with the patient who'd recently had a head trauma if they were showing, you know, X amount of millimeter in diameter of pupillary or non-pupillary reflex. So these are kind of good things because it's showing that you understand about the importance of the, you know, contralateral brain injuries and that. So that's the optic nerve examination. If you do have a fundoscope, so I guess if you're doing it in the university or in a clinic, you probably would have a fundoscope. If you do have a fundoscope, definitely use it, because that's another good point to show off your skills. And it's another great point that you can link pathology, because with the fundoscope examination, you can talk about all of the things that we just mentioned. So you can say, well, you know, I would definitely use the fundoscope examination in my patients that are hypertensive, because they're very at risk of things like problems with the arteries, optic disc degeneration. I'd be really interested in my type 2 diabetic patients looking for type 2 diabetic retinopathy. That's all you need to say for that. I mean, that covers it, because that's the majority of the patient population. You can also mention about macular degeneration within the elderly. So the fundoscope's a great way to show off your skills, because you can talk about 3 or 4 pathologies here. Hypertensive disorder, I'll just write them down: hypertension, HT, diabetes, diabetic retinopathy, which all comes under diabetes, and macular degeneration. All of these things are really good discussional points. And also trauma as well. So if somebody's had a really significant facial trauma, like the different types of Lafore fracture, you might also want to just have a look if there's any damage to the eye itself. Then the ocular motor nerve, we're looking for depression. So we're looking for abduction via the medial rectus, depression. So again, you can discuss the movements of the eye and discuss the normal movements of the eye in relation to this particular test. The same with the trochlear nerve, and mention with the trochlear nerve's a really nice one to drop in about it being the most significant nerve to be tested. So the trochlear nerve is really very a good one to talk about, because it's the most susceptible to damage from intracranial lesions. So on this one, when you go and do your trochlear nerve exam, make sure that you mention intracranial lesions caused by trauma, inflammation, and inflammatory disease. So you can talk about any number of inflammatory diseases. I mean, inflammation and inflammatory disease is the bread and butter of your profession, really. So this is a very, very good one to expand and to just impress them with your good medical knowledge. Then the trigeminal nerve, as we said, it's the most complex. So, I mean, you can say that within the exam, you know, it's the most complex of all of the cranial nerves. And it has very, very specific parts that we want to test. We want to test the ophthalmic, the maxillary, and the mandibular divisions of this. And what we're looking for is symmetry and normal sensation on one or both sides. And as I say, Manny, you can either do this individually on one side and then the next side, or you can do it both sides, or to be on the safe side, you can do the whole lot. So for the day, it's probably advisable to follow it like this and just to do as it's written here, and just go from one side to the next, from one side to the next, from one side to the next. And then what you can do is you can just double check by going down both sides, and then you ticked all of the boxes. You've doubled up on it. You know, it's not a bad thing to do that at all. This particular one, as you said, the corneal reflex, the blink test, you're probably not going to do that in your OSCE, but you can certainly talk about it. And you can state the reason why you may select a patient to particularly do this, because you have concerns because they've had other positive or negative signs in some of the other tests that you've done before, as well as the jaw as well, checking for the deviation of the jaw. Now, what you can do is you can link this to what we talked about yesterday in relation to TMJ. So this will link in to your TMJ. So make sure that when you go over the jaw opening and closing and movements of this in relation to the trigeminal nerve, you also relate that to the TMJ joint dysfunction, and also you can relate that to things like fractures and dislocations at the jaw. So you can also talk about the ligaments that we talked about yesterday when we talked about the laxivity of the jaw, and we talked about the ligaments around the jaw. I mean, obviously you have a fairly short amount of time to get through all of these tests, but there's just certain points that you can drop in that really just help with your marking. Then you've got the abducens nerve. And so again, with the abducens nerve, you can just discuss eye movements. And similarly, the way that we said with the trochlear nerve, consider how eye movements, normal and abnormal, relate to things like lesions of the brain and head injury. So it's all about head injuries, really. The facial nerve, the tests of the facial nerve. So we said about the symmetry or asymmetry, opening, closing of the eyes, puffing of the cheeks, and the smile, opening the mouth and forming a smile to look for normal movement of the mouth and the face, facial expression for facial nerve and facial nerve palsies. Vestibulocochlear is to do with hearing and balance. And so you're going to use your tuning fork to do that. So you're going to do the Rinne and Weber test. So as I say, if you do like me, when I have done these things over the years, these OSCEs, for my own learning, I've had to lay things out in a certain set from left to right. So I just remember where everything is. So, you know, you get your visual acuity tests, and then this, and then this, and then this. So just practice laying your equipment out, just so you don't do one test before you do another. Then the glossopharyngeal, we talked about the 5 components of that. and the gag reflex, so the R or CAR, and the deviation of the uvula is the significant part of that. So if you have deviation to the uvula, that's the main significant component of that. The vagus nerve, we mentioned about the vagus nerve. We started to look at the vagus nerve in a lot of detail over the last few weeks about the how it goes to form these various plexus, and we're still going through that. Obviously, you're not going to have time to kind of go into huge amounts of detail about the vagus nerve, but you can talk about the major signs and symptoms of problems within the vagus nerve, which is ultimately going to be problems with patients swallowing and hoarseness. So these are patients who have some kind of problem with the vagus nerve. They're going to have difficulty maybe in eating and drinking, and they're going to have a change in the tone and pitch of their voice. And then the spinal accessory nerve, this is the nice one that's going to finish off this bit and lead us on to our next part, is to do with the muscles of the larynx and the pharynx and the innervation of the trapezius and the sternocleidomastoid. So this is where we get our patient to shrug the shoulders and to turn the head. And so you can discuss that. So, I mean, this is very familiar with you. This is the kind of test I imagine that you do all of the time. Good. And then the last one is the hypoglossal nerve, cranial, 12th cranial nerve is going to supply the efferent motor fibers from the tongue. And here you're just going to get the patient to put out their tongue and move it to the side. And you're going to look to see if they have any weakness on the left or right side. So this is a test that I'm sure they'll ask you to do, or they'll expect you to do within your OSCE or your patient presentation. So you can just discuss that. Manny, is there any questions about anything that we've covered?
There's two which have come up. One is one of the tests is I don't know if you do it the convergence test and divergence. So a convergence test, when you look at an object in front of you and you tell them to look behind it, and then in front of it and look at pupillary constriction.
Yeah,
that's one of the tests. Is there any particular reason why it would like, say for example, it's not used, or any particular reason why it won't be used as much?
Why it's not used? It's not used because the tests that we are doing test for every component of the eye, and all of the motor, all of the somatic, visceral, and efferents and afferents, and all of the visceral efferents and afferent components. So the test that you're mentioning, it's really kind of down to it's almost like a clinician choice into whether they use it. I mean, I hate to say this, but there's not really a wrong or right way to do this. But there is, when it comes to the exam, they expect it done in this specific order. Now, I mean, with anything, once you qualified and you go off and start your own practice, or you work for yourself, you could do that. You find people do this in any which order, and so some people may well use to do that. And in fact, certainly a lot of doctors I've known, a lot of doctors I've been to, will do it in totally different order. But the main objective is all of this. Really, this presentation just shows all of the things that you need to test, all of these components. How you test those components is up to you. In the sense that it's up to you. Once you've done all your OSCEs and you're finished and you got your license and whatever, then it's pretty much up to you. But as long as you perform all the tests, so. I mean, when it comes to visual acuity, reflex, and all of that, yeah, certainly you can do that. And the only thing is, the only thing I would argue is following this routine ensures that you don't miss anything. So, for instance, what I have found over the years is certain doctors I've worked with or I've been to myself, they might do like you're saying, they might have a test and they say, okay, look at the cup, track the cup, and then look at the distance, look at the far wall. And they're testing to see, they're looking to see if your eye deviates and things like that. But then what they might do is they might forget the intricate detail, like of looking at the tip of your nose to see if the eye moves away, or they might, there's just certain aspects like that can be missed. And in fact, certain cases I've actually had it done to myself where I've been and had a medical done and they've done everything apart from bothered to flash a light in my eye. And I was like, well, that's crazy. You've done everything. You've done you've done the quadrants, you've done the close up, distance, but you haven't bothered to flash a light in my eye. And then some people will argue, well, I can see that your pupil is dilating or not dilating because there's light coming in. So I mean, yeah, if that, you see what I mean? It's a difficult one, Manny, because you can go into as much or as little detail as you want, but for the purpose of an exam, this is the method to stick with.
Okay, that makes sense.
This is the method to stick with, and the thing is, you can talk through this, because with each one of the exams you have a rationale. There's a rationale for each one, sense of smell, changes in the sense of smell, visual acuity, color blindedness, visual fields. Can the patient track? Can they not track? These are all things. The optic nerve examination by fundoscopy. These are all things that are really relevant. I mean, like you were saying about fundoscopy, how many people don't perform fundoscopy? Loads and loads and loads and loads of people do not perform fundoscopy. Is it a good thing to do? Yes, it's a darn good thing to do, because you can see loads of stuff that's going on just by looking in the back of the eye. You can even sometimes you might have a patient that comes in, and this might be one of the only tests that you're involved with, but as soon as you look at the back of the eye, you think, wow, I'm sure this person's hypertensive, or they've got, early signs of macular degeneration going on. So it might be you that just by looking at the fundoscope, you could save their vision, or you could save they might be a really risk of diabetic retinopathy and all kinds of things like that. So, I mean, it's a simple thing that is overlooked, unfortunately, but it shouldn't be. These are all standard tools. Really, these are standard tools that we should all be using. Everyone, doctors, nurses, everybody, really, they should be doing these standard tests.
Cool.
Okay.
That's it.
All right. Okay. Well, should we just do an hour and then come back in an hour, or do you want to give it a couple of hours?
No, we'll do it in an hour. It's fine.
Okay. Perfect. All right. Well, I'll get the next bit set up and have a coffee, and then we'll get back to it in an hour.
Amazing. All right. See you in a bit.
Perfect, Manny. See you in a bit.
Bye.
Thank you.